This is the next of the talks given by me, Dr. Russ, one of the GP partners here, because the PPG gave me a list of topics to talk to the patients about. The PPG is the patient participation group, who are friends of the practice, who tell us when we're doing good and when we're not doing quite so good, which is fine. Yes, all the information is here. They're great. We love our PPG. They are very honest with us, which is absolutely fabulous because that's exactly what we need them to be. But they asked for a number of these presentations to help with some information, both for them and for the patients, which is also great. This, I think, is the last one I have a title for, by the way. No, there is another one?
The next three are...
Oh, the next three are filled up, are they? Excellent, lovely. At one point they might tell me what I'm talking about then. This was quite a useful topic because I already had a set of slides prepared from just short of a year ago on having lectured on the similar topic before. So it's always helpful when they pick up ideas which I've already got the work for. It saves me having to repeat everything. This is a set of slides that was put together by myself and several what were then GP registrars to do a small presentation, mostly for them to learn about putting presentations together more than anything else. So it was teaching them to lecture, and this was the subject that we were choosing. Both of those have gone on to qualify as GPs now. So these were doctors training to be a GP. They are now both GPs. One of them is currently working here, is a mat leave locum, and one of them's just gone to work in Worcester, having completed her training last week. And I was planning to update the slides a little more. Unfortunately, I had a family emergency today, so I haven't managed to go through them in great detail. It will become obvious. I was skimming through them before I started and thought, oops, at least one of them is now out of date slightly by a year. It will become obvious because it mentions dates and they're a year out. I'll update that one as I get there. But otherwise, nothing really much has changed. Yes, the title I think that was concluded was, this bit I did update because this matches the PPG's title, which was how to get the most from a GP appointment. Sounds like a reasonable title to start with. Although it takes some pulling apart to actually work out what that means. To fully understand what we're going to try and get out of it, we need to understand a bit more about what the GP appointment is and how the whole process and the system runs. So that's what we're going to try and work through. That button there we go. So that should give us a set of aims. Oh, hang on, I've got a pop up here somewhere. Where's my mouse gone? There it is. Come back here, mouse. There we go. Now it's got my pop up out from all of my words. We'll look at understanding modern general practice. Those three words actually mean something because since this was written, the Secretary of State for Health and Social Care has instigated a capitalised modern general practice into the processes that the NHS and NHS England are asking us to provide. So at the time of writing, modern general practice was an idea, a theory, that's now actually been incorporated into standard everyday practice, and there is an expectation that all GP practices practice modern general practice. We'll talk a little bit about what that is as we go. We'll look at what to prepare for an appointment. I'll also, on the flip side of that, look at what GPs and clinicians prepare their side before an appointment. We'll do a bit on triage and care navigation. Again, a very specific phrase that you might not have heard of before, so we'll expand what care navigation is. We will talk about online access because that always comes up in topics like this. Why does everybody insist on online access for everything? Again, this was a year ago, but even then we were talking about tech and AI and artificial intelligence and its role in the GP consultation, what it brings and and how that might change the way the consultation behaves a bit. And then we will also leave us with some practical tips. So the sorts of things you could use tomorrow if you were coming to see a clinician in the White Horse medical practice tomorrow. So rather than just all of me talking about the theory, actually giving you some ideas as to what could work. So does that seem to fall in the areas that people, good, excellent, super duper. If there will be some questions, and you feel free to ask questions as we go. There's also time I've allocated at the end if there's just random questions. Please note that none of the targets aims tonight is to talk about meningococcal B meningitis. That's not on the list. If we really want to do something about that, we can talk briefly at the end, but for now, despite the tragic events in Kent, I'm not planning on talking about that because that wasn't around a year ago. Well, it was, but it wasn't around this time. Kent is a very long way away, yes. Sweet, so, oh, hello, now I've moved my mouse, it's not going on to the next one. There we go, so, the modern GP practice, modern general practice, this phrase is now thrown around and is actually now contracted in that we are obliged by the NHS to be a modern general practice. Yeah, that's helpful, isn't it? So what does this mean? Now, the first thing to look at when we're talking about modern general practice is that it's not about GPs. It's about general practice, the space, the building that we are in at the moment. So when the system talks about modern general practice, it's talking about the team that we are working with, which is GPs, the experts in diagnosis, the experts in risk management. Do we have to do something about this? Can we wait? How quickly do we need to do something about it? Is this oh dear, we need to panic and call the big yellow bus with noisy blue lights on the top to come and take them away? Or can we do other things? We are the risk managers in all of this, and we are the complex decision makers. So the GPs take the most complex cases, the most difficult to manage the risks within, and try and formulate a plan that works with the patient, and we'll talk a bit more about how we get there, but that's what the GP is doing in all of this. We also have ANPs, that's an abbreviation for Advanced Nurse Practitioners. So these are nurses that have done additional skills both to work in general practice and to bring other ideas in. At least 3 of our nurses here are independent prescribers, so don't need to seek a doctor to write a medical prescription. They can do that themselves. Yeah, there we go. So yes, that's what. So they are a hugely important part of the modern general practice team. We have one physician associate with us at the moment who also helps to support the GPs and the AMPs. So obviously, physician associates you may have picked up the fact there's been some noise in the press about them recently. As a profession, they are now licensed via the General Medical Council and thus have a protected title in the same way as nurse and doctor have a protected title. You can't claim to be a nurse if you're not one. That's illegal. You can't claim to be a doctor if you're not one. That's illegal. You can't claim to be a physician associate if you're not a fully registered physician associate. So that brings them in line with a clear set of understanding as to what it is and what they do. But generally they fit in around everybody else. They can do a bit of everything. They're not as good as a GP. They're not as good as a nurse practitioner. But having people who can fill into slots all over the place adds to the resilience of the modern general practice and means it can keep going because you've got somebody who can do a bit of everything, which is really vital with a team of our size to make sure it can keep running because they can fill in all sorts of gaps in the short term as we need to. We have clinical pharmacists. Because of constraints on our building, our clinical pharmacists don't actually run out of the building. We've ran out of rooms to put them in. We ran out of chairs to sit them on because the building isn't big enough for the whole modern general practice team. We won't talk too much about that issue, but there we go. So ours are remote clinical pharmacists, but they do medicine reviews specifically focusing on polypharmacy, so that's patients on lots of drugs at the same time, and the interactions between those, because pharmacists are great with drugs, of course. That's kind of what they do for their day job. And they also help us with managing repeat prescriptions in the background without actually communicating with patients. We've got first contact physios, sometimes referred to as FCP physios. These are diagnostic physiotherapists, so they will see people with musculoskeletal problems for which we currently don't understand the diagnosis, the cause, and don't have a treatment plan for. They aim to see people once or possibly twice, especially if they need to arrange investigations like an X-ray to help with the diagnosis of the patient. But once they've got the diagnosis, they will then refer on for further treatments as needed. So if they can't treat them with a single treatment in general practice, they refer on. So they are a single or a couple of contacts to diagnose a musculoskeletal problem. It's estimated that about a third of the contacts with general practice, a third of the requests for help from general practice, include at least in some part of that contact a musculoskeletal problem as part of the presenting complaint that we're trying to manage with the patients. So these are a huge part of our team because the demand for musculoskeletal diagnosis and treatment is very high in general practice. And in a population like ours, which is aging, because it is, we watch the demographics on a regular basis at the practice, our practice average age is getting older, we are going to get more of that. They work both remotely and in person. I'm sure many of you will have met them. One of them stands out because one of them can't see, so has a obvious white stick and various visual aids that we work with to enable her to do a job. She's absolutely brilliant. It's amazing what you can do when you have to do everything via touch when you're trying to diagnose musculoskeletal problems, isn't it? Yeah, works really well. She was also a Paralympian, which makes everybody very jealous of her. I know, she's done it all. It's like, really? Stop it. And then there are others. We have a mental health practitioner. We have one mental health practitioner. We had to fight like hell to keep that one. They tried to take him away from us February last year. We have two paramedics that work with us. One of them is an advanced paramedic practitioner, so can now independently prescribe in of themselves. Obviously, paramedics are really good with acutely ill patients, so patients who might be have picked up an acute illness, a sudden illness, baby ill. They're really, really good at screening out that risk. So those patients where they could be seriously ill, do we need to assess them and do anything else immediately with them, like now? And of course, if someone does come into the practice who happens to be really ill, it's great because the GPs go, what are we going to do? And we go, call the paramedic. Fabulous. It makes everybody a lot more relaxed in the building to know that they're around. We obviously have social prescribers. Sarah's in the room with us, so we will say absolutely gorgeous things about the social prescribers. Aren't they awesome? They're completely the best. We couldn't carry on without them. We have to say all those things because Sarah's at the back of the room. Our social prescribers are great. They are exactly what it says on the tin. They are social solutions to social problems. It's part of our drive in modern general practice to provide a holistic solution for patients that includes trying to resolve problems which are not medical but will turn into an illness if we don't resolve the social situation that's around them. And that can be many things. The most common of them is just arranging social contact for people who become isolated and alone. We've got an ageing population around here. We've got lots of villages which are very isolated around here, which are part of the catchment area as well. So being able to make contacts and to have human beings with other human beings is hugely important to their health and well-being, and the social prescribers help us to fill that gap. They also have a bunch of other things they do, including connecting with non-traditional medical treatments like exercise and activity. And the park run, yeah, absolutely. Yep. See, both gets people in social contact and gets people exercising as well. And the other things like smoking cessation and weight loss and diet control. There's all sorts of solutions for people out there. It's about finding the right ones for the patients. And GPs are really bad at that. I mean, it's, if I can't write a prescription and solve it, it tends not to be the sort of thing that we're doing, whereas the social prescribers fill that holistic gap in our needs. And we have care coordinators. Now, the care coordinators here mostly operate in the background. Some of them will see patients from time to time with complex needs, but most of our care coordinators are there to coordinate pathways of care for patients. The classic being, say, a cancer or urgent care pathway. If we put a patient onto a cancer or urgent care pathway because we think there's a risk of them having a cancer, we have a care coordinator who follows that through. to make sure that the patient gets along the pathway without falling out of the system. We have complex systems around here because the Great Western Hospital has a different system to the John Radcliffe Hospital, which has a different system to the Gloucester Hospitals, which has a different system to the Reading Hospitals. So if you don't have a person watching this, patients can fall out of the system and get lost in amongst it all. And we have had some instances of that happen in the past. So now we've got people who monitor those through it. One of our care coordinators also looks at the aftercare of patients who've been diagnosed with cancer. So how we can support them after the diagnosis as well, should that be made. She does actually see patients around that. They monitor things like the coordination of care for patients with learning disability. So they make sure that all of those patients are regularly assessed. So that's the sort of thing that the care coordinators do. And we'll do some of it face-to-face, but a lot of it is a background series of coordination work that's going on. So that's a modern general practice team. Oh, hello, I've skipped ahead a bit. There we go. Any obvious questions about the team? So that's what largely people mean by modern general practice, is not just a GP, effectively. It's a GP plus all of this additional stuff around it. And as the owners and managers of this organisation, instead of just running a GP service, I now have to run all of this at the same time. Hey, go me. Yeah. Yeah.
It's a modern general practice,
yes.
Not a modern GP practice.
Correct, yes. A modern general practice contains GPs plus all of this.
So it's not a modern general practitioner's practice.
Yes, it's a
you have a slide saying modern GP practice.
Yeah, I know. It's just because I was lazy and when I wrote the slides up. Yeah, no, you're right to correct me on that one. That's exactly. But yes, you're correct. It's not a the goal, and the goal when this was set up was that it would expand the GP practice to include all of these things. The current government has taken it one step further with the concept of care closer to home, which you will keep being repeated by the current government system at the moment. We're not quite sure how this is going to morph into the provision of care closer to home. I mean, how many more things do they want us to do than what we're already doing? If they're bringing hospital work out to us, is my modern general practice team now going to include paediatricians? Is that going to be added to the list of people that I'm trying to manage and coordinate in the practice? And the more we expand it, there is a risk of a loss of vision and a loss of focus. And so there's a lot of talk going on around the edges as to how we maintain the focus on the patients whilst expanding the team and the offer that we give the team, because there's clearly a pull in different directions at the same time there.
So how much interaction is there between a general practice and the ambulance service, for instance? I saw on telly the other day that they're going to start having paramedics going into people's homes and doing a lot more of them.
Now, the answer to that is it depends where you are in England.
Right.
Around here, yes, it is a postcode lottery. And around here, the postcode lottery doesn't run in your favour. In fact, in an SN7 postcode where we are, it's pretty much at the bottom of the table of favours, because this is about one of the worst postcodes you can live in for those sorts of challenges. The reason is that South Central Ambulance Service and Oxfordshire Place haven't managed to communicate in any sensible way at all, and there is no current data sharing in place. For instance, interesting now, of course, because of what's going on, I can see the activity of Kent Ambulance Service. I have the online data for everything that's going on in Kent right now. I don't have any of the online data for anything that's going on in Oxfordshire. Why can I see what's going on in Kent and I can't see what's going on in here? Because they can't arrange the data to flow in the correct way. And there is currently no process for me to be able to see any of the data from the Great Western Ambulance Service and the service for Swindon and Wiltshire, which will sometimes turn up. If you dial 999 from the practice car park in an emergency, you can flip a coin. Sometimes you'll get SCAS and sometimes you'll get GWAS, because they'll all come out of the services just the other side of the Wiltshire border. Yeah, and so have you experienced the Great Western Ambulance?
Yeah, we had a car accident right on the border of Oxfordshire and Berkshire.
Yep.
So we ended up with two Oxfordshire ambulances,
Yep.
one Berkshire one,
Yes.
and a Berkshire fire engine
Yep, there you go. Now the Oxfordshire ambulances and the Berkshire ambulances at least have the same communication system and can talk to each other. The Oxfordshire ambulance services and the Swindon ambulance service can't talk to each other. They use completely different data systems, completely different databases, completely different coding inside their IT systems, and there is currently no method of pulling all of that together in a single source of communication. I had thought I was making some progress at getting the Whitehall's medical practice to be able to talk to both of the ambulance services. Unfortunately, with the rearrangements in the integrated care board at the moment, that looks to have fallen apart again. I've been going around this circle for about 9 or 10 years trying to resolve this clash, and I've still not managed to make any significant progress with it at all. So the answer around here is you're in the wrong postcode if you want to communicate with the ambulance service. Yeah, it's unfortunate that, isn't it? Will we be getting, one of the other things that they've been talking about with the modern general practice and expanding the teams is individuals like the district nurses, which are separate from us. And you'll notice I'm not on that team because I have no control over the district nursing team at all. I can't order them to do anything. I can ask them to do things. They can say no, at which point I can go, okay, because once they say no, they've said no, and I can do nothing about it. So I have very limited influence over how many district nurses there are, what they're doing, who they see, when they see it. So there has been talk about moving some of those back into this sphere of influence to make a modern general practice that encompasses some of those. Health visitors, again, I have no, despite the fact they're in this building, we have very little interaction with them at all.
So when we actually phone in for an appointment, does it start at the top and twiddle all the way down?
No, it doesn't. We'll look at that one in a moment. And that actually, you've come onto you have anticipated my next slide.
Okay.
I like this group, they're good. You could come again. Why the receptionists ask questions, and often people ask this when you ring up, if you ring up, or when you fill in the online form. If you fill in the online form, you're filling in the same questions as the receptionists have asked you. You've probably realised by now that the receptionists are reading off a series of questions and filling in the blanks on a form. That's exactly what they're doing. They're using they have the same form as patients have online. There's no difference between it. It's just that the receptionist is filling it in upon your behalf, which is fine. That's absolutely, we have no issues with that at all. But just to understand in the background that is exactly what they're doing. And the reason for this is that they have a care navigation role. I told you I was going to come back to this one. We have a group of senior receptionists who are now called care navigators, because that's the national phrase that everybody uses, whose role it is to support us to get the right patient for the right clinician at the right time for the problem that they are presenting with. There is a clear efficiency in running general practice if you get the right person, the right treatment at the right time with the right clinician. If you get that wrong, you're making an inefficient system that is likely to, firstly, potentially harm the patient, and secondly, it just costs lots of money and time, and I haven't got lots of money and I don't have any time. So the idea is to try and resolve some of that by navigating through. So they don't start at the top. They've effectively got a blank sheet with all of those names on it, and they can try to work out who is going to best fit where. As well as the care navigators, a GP will work with them to attempt to support that as well. But all of this is about right person, right place, right time for the right treatment. And if we get that right, we end up A, making the patients better, which is kind of the goal in the first place, and B, doing so in the most safe, prompt and efficient way that we can. We are, after all, a taxpayer-funded organisation, and the taxpayers like us to spend the least amount of money we can to get the maximum benefit at the end of it. And that's entirely reasonable. I pay tax too. That's what I prefer the system to do. Urgent versus routine is handled slightly differently. Any information coming into the practice that suggests that the problem is urgent and needs attention now is flagged as such by the people coming into the, or either by the automated system or by the receptionists when they type the system in, and that will go to the top of the list. That's reviewed by a senior GP as soon as the next urgent slot's available to review it. It rarely takes us more than about 4 or 5 minutes to get to the next urgent one, and then it will be handed over to somebody else. So that GP won't solve the problem, but they will make sure that that urgent problem is given to the right person to solve, or they will downgrade it from urgent because they don't think it is. That's fine. We're a risk management specialist after all, and we may manage the risk by going, actually that's not as urgent as it appears to be. To support us in that, we have a system that runs in the background in the practice, which identifies the patients most at risk of hospitalisation, because they've got codes in their records, diseases in their past, episodes that have occurred in their past, which makes them at risk of hospitalisation from worsening of those illnesses or from things like an infection that comes up because of those illnesses. They are automatically flagged, and no matter what they ask for, they go to the top of the urgent list, and they are assessed by a GP to see whether it is actually urgent or not. So even if they don't ask for an urgent assessment, in the background they get one anyway, at least a brief one, to see whether this is an urgent problem or not. So those patients where immediate hospitalisation is a risk will get flagged out. That's not just physical patients, that will include those who are at risk of hospitalisation in the mental health services as well. So we have a cohort of patients who have unstable, serious and enduring mental health problems where we may need to act quickly to prevent that deteriorating in a hurry, and those also get pulled out and put at the top of the list. Again, and they could just put in a fungal nail infection as their request. It'll still go to the top of the list and still get a triage by an expert GP to make sure that it isn't actually something hiding as a fungal nail infection that's more severe. Does that kind of make some sense? So that's the kind of urgent routine, and that's it. I mean, there are two types of cases. There are urgent, and there's everything else. There's no spectrum in between. Yep.
Systems running in the background.
Yep.
Is that an automated system?
Yes. Yeah. In that, every month it updates the list of patients, and the list of patients is plugged into our online consultation system, which is the same thing the receptionists are filling in, and then it happens automatically and just flags them as they go.
It's not an AI system.
It's not an AI system. I will talk about tech and AI. Yeah. There is no AI involved in that at all. Right. Yeah. Yeah. No, absolutely not. And that was a very conscious decision to not put AI in there. Sweet. There are times when we need to give out brief help because it's the safe thing to do with the patient. What that effectively translates as, there are patients who will put in a request for help where we go, whoa, that's not general practice. When they ring up and say they've got central crushing chest pain radiating to their left arm and up to their jaw, and they think that they're very ill and they're sweaty and they're pale, which we get every day because those calls come through on a regular basis, they will be told they're in the wrong place. You need to hang up and dial 999. You know, we've had at least 3 people today who rang up saying, I think I'm having a stroke. This is a general practice. We can't manage that kind of emergency here. They need to be in an emergency department. So the brief intervention is about picking those people out who've chosen the wrong part of the health service and direct them to the correct part of the health service. If it's ambiguous, we will from time to time direct them towards the 111 triage service. The 111 triage service is more detailed than ours, uses a system called NHS Pathways, which has a medical evidence base and is constantly tested across all of England, and is much safer at managing the risk of those patients where it's intermediate and we're not quite sure what's going on. They can refer back to us, so 111 can say, actually that is suitable for a GP, and they can put them back into our system for it, and 111 can go, oh, no, I'm sending you an ambulance now. And they can do a whole bunch of things in between. Of course, I can't send an ambulance now because I can't get hold of the ambulance service in such a way. The 111 team are in Bicester in the same room as the 999 team. They're literally in the big same open plan office.
They ask too many questions.
This is designed to ask lots of questions. That is deliberate because they need to assess the risk and what needs to happen as a result of it.
No, they asked me my date of birth.
Mm-hmm.
I gave them my date of birth. They then asked me, was I pregnant?
That's not working then, is it? No, I agree. That pathway has got broken. There are supposed to be assessments within the pathway to stop things like that happening. It's not perfect, you are right. It is, as far as we are aware, the best system that could be used to achieve that.
My son grabbed the phone and said, dial 999 now.
Yes, that may not have been the worst idea. The 999 system wouldn't ask if you were pregnant, only the 111 system would. Yes, you are right. It isn't completely perfect. It does make mistakes from time to time. You can actually, if you're interested, you can look it up, because the data that comes out of NHS Pathways is public, because NHS England publish it through their website, or is it a gov.uk website? Anyway, it's all out there. It's all general public data. So you can see the number of failures because it comes up on their system. And they do try and reduce the pathway errors. It's a very, very complicated set of pathways to get right every time. And sometimes it doesn't quite. But that's that.
They obviously read it from a computer.
Yes, they do. Yeah. The operators are reading it from a computer. They are backed up by nurses in the background who they can refer the case onto, but they have to get to the bottom of the schedule before they can do so. Yeah. But yeah, that's why we use 111, is an attempt to pick out those patients where we don't know whether they need brief emergency assessment or whether they need to actually come into general practice. Online forms, the other thing is that sometimes people don't like talking to the receptionist because, now I know lots of people do like talking to a human being, I hear that, I get that, but there's also the flip side of that coin. There's a whole bunch of people who don't want to talk to a human being on the telephone, especially because our receptionists here, they are brilliant, but they are also mostly local. I mean, the vast majority of them walk to work. Now that's great, because that means they know the population that they are trying to help here, and that's real value to the practice. But the flip side of that coin is, if it's their neighbour, do they want to tell the receptionists about their rather personal issue? You can see how that could be a problem. And one of the advantages of the online reception questions, which is what the online form is that that doesn't happen, because you've got that sense of privacy within it. So one of the other things that the reception team will do is to suggest to people, if they're struggling to speak to them, that they just go away and type it all out, because sometimes that actually is a lot better. Cool. And that leads nextly on to triage, which is back to right patient, right appointment, right time, right clinician. And the whole purpose of triage is matching the problems that the patient is listed to the right place. It sorts urgent from routine. I've already discussed some of that, because that's done within our automated system. And as an attempt to inform fair access. There are some wobbles in our system, and I won't go into them in great detail at the moment, but actually on days like today, it didn't work exactly as we wanted it to, so we're doing some work in the background. Actually, Dr. Masterman's leading on it at the moment to do some data analysis to see exactly what's happening there. But some people are getting appointments sooner than others, when it should be the other way around. So we're working on that in the background, because it's not quite gone as we wanted it to. There's also been some problems with the telephone lines, in that was prioritising some calls over others for reasons we didn't fully understand. We have an external telephone company who provides a telephone system, so we're doing some data analysis in the background there. I think we've got solutions to both of those. So, but the goal is to ensure fair access, and we identified the fact that we weren't doing it, so we're trying to fix it to ensure that is actually happening. It books with the most suitable healthcare professional to resolve the patient's problems. The online screening, or the short phone screening, and sometimes in order to complete the triage, we will get people to phone the patients back. So one of the things that if we've got an online form which is incomplete, the care navigators will ring the patient to fill in the bits that we're missing. So sometimes short phone additionals are added into the system here. The whole goal is that if we get this right at the start, we save time and effort further down the line. So the whole goal of triage is about that efficiency within the organisation. So, given the fact that you've now been triaged to your appointments generally are about 10 to 15 minutes long. Sometimes they can be longer if we need to sort out complex things. So, what do we do in our 10 to 15? So we've been triaged to our 10 to 15 minute appointment with a suitable clinician. What happens in that appointment? So, the first thing we as clinicians want to know is, what is the top concern? What worries the patient the most? And you will hear the receptionist asking you this if you ring them up, or you've been asked to fill, because the box actually says, what is your primary concern? It asks you to type it up if you're filling it online. We use those words exactly. We will ask things like the timeline, when it began, what's changed, what's made things better and worse. So you'll be asked those as part of the triage process and in the appointment. You may be asked to bring medication. We of course know what medication we're prescribing you. There's no point in bringing that back to us. But we're not the only people who prescribe medicines in the NHS. They do come from hospitals, and hospitals are tediously slow about telling us what medications they've given the patients. Sometimes it can take 4 weeks for the Great Western Hospital to tell me what they've bloody done with a patient, which annoys the hell out of us. So sometimes we'll ask you to bring medications because we don't know what you're talking about. And increasingly commonly is the private access to medication. The most common one of those that is privately accessed by our patients is weight loss injections. And we have well over 1,000 people privately purchasing weight loss injections that are currently registered with the practice. And we don't see any of that process because none of that is communicated into the practice. So the other thing for bringing medications is to see if they've got them from elsewhere. Young ladies can get their contraception from the chemist now. It's free. That's a great thing. I like that. I like more access to contraception and more choice for young women. That's fabulous. I mean, I'm a father of 3 teenage daughters. I'm not going to get in the way of any of this at all. But it does mean I don't get to see what they're doing, because that also doesn't end up with this as well. So we might ask people to bring medications. If we do, the actual box or the picture of them is the most valuable. Writing things down doesn't tend to work very well unless you're really versed in the medications that you're taking and what you're writing down, because medication names are long and complex and don't often make any sense whatsoever. So it's usually easier if we actually have a photo or the box itself, because it prevents us getting errors there. Dentist will, the dentist will also throw a curveball in from time to time. Yes. yeah.
Also ask about anybody that's on research programs.
Yep.
Are you fed the information?
It depends what research program they're on. It will be listed in the ethic committee approval for the research program as to whether the GP is informed or not. And the ethics committee will have decided whether that should or shouldn't happen, and it will vary from program to program. Most of the time we are, but there are some that for the purposes of successful research needs the GP to be blind to what is going on. And of course, if they're in a double-blinded trial where there is a treatment dose and a placebo dose, I won't have access to the breaking of the dosing to know which one they're on. So, for obvious reasons, I mean, the trial won't work if the GPs know what drugs are on. The photos are things that change. So if you've got a bit of your body that is reacting, often this is skin rashes where the rash comes and goes. There's no point in bringing your skin to me if the rash isn't there. I can't diagnose it anymore, it's gone away. So photos can be helpful if there is a thing that comes and goes, and they can be really useful to us. And home readings, increasingly more common as tech becomes more accessible at home. It used to be just blood pressures from blood pressure machines, and often ones that we'd lent from the practice because they were expensive. They're not expensive anymore, and people have access to a whole range of tech and ability to record their home readings. Those home readings, the raw data is the bit that we often want. People often bring in their interpretation of the home readings. All those years at medical school, all those years as a junior doctor, all those years training to be a GP, I've probably got an idea how to interpret the data. Your Google AI might not have got it quite where we want it to be. So what we actually like is the actual raw data, because that can be really helpful. Most of the tech can drop the raw data out of it if you know how to do it. And increasingly that's becoming more of a thing. In fact, while we're here, I know we run digital, are the digital cafes still going? I don't know if you talk about tech and monitoring at home in those at all or not.
I don't think so.
Okay, we might have to have a so this is a learning point for me and Sarah, our social prescriber tonight, is to see if we can have a chat about how we can advance that so that we can see where we go with some of those, especially with some of the really complex stuff like the blood sugar monitors at home, the capillary, the ones you stick on your arm. You've seen these white discs that some people with diabetes have stuck on their arm. I mean, the most when we used to do these, we used to mention Prime Minister Theresa May when she was the Prime Minister at the time, because she used to have one on her arm because she had diabetes. So they can be, but they are really complex in terms of the data that you get out of those, because you get a continuous blood sugar level for the patient for a week, every minute of the day for a week. That's a lot of data coming out of these. So, but even those, we would like the raw data, and we have systems to interpret that inside our system to help us understand where we're going. And if you are bringing multiple issues, or you're speaking to the receptionist and you've got multiple problems, or you're putting in your online consultation, you've got multiple problems, having some sort of idea, your side, as to what the patient thinks the most important problem is to them. And yes, I might look at that list and go, oh, blimey, that sounds serious. I get that, and I will do that. But it's also really valuable for us to know what you think is the most important problem to you, because I can't solve your most important problem if I don't know what your most important problem is. And if you're coming with a list of problems, and as people get older and get multiple diseases at the same time, and have multiple long-term conditions at the same time, we are going to see more and more people with a cluster of problems coming up together. Now that's fine, I'll help to weed out the most risky problem, but I also need to know what's the most important problem to you. And if you don't tell me, I can't act on it, which is why the receptionist will ask it and why we will ask it in the online consultation bits and pieces. And when you do end up in a consultation with us, we will repeat that all over again. Fine, so now we've talked about the sort of rough ideas. Let's look at the GP consult. Now this is actually based on the GP consultation, but to be honest, all of our healthcare professionals use the same model of consulting, so it doesn't really matter too much. The consultation, there have been, now I've got several healthcare professionals or retired healthcare professionals in the room with us at the moment. You've all been through you've all looked at the consultation model with the GP and how this is, all works. It's been studied in detail for a long time. The most extensive studies come out of the late 60s and early 70s with a piece of work done by now Professor Roger Neighbour, who's still going and still lecturing and still looks like he's stoned in the 70s. He is a character, Roger Neighbour. However, he did a lot of good work in drawing up some basic ideas about what a successful healthcare professional patient consultation would look like in this setting. And whilst very few people use his structure model anymore, because that was the 60s and 70s and we've moved on a bit, all of the models effectively are based upon that as a foundation that moves forward. It's moved into hospitals as well. I'm not sure if you covered that kind of, but these days it's now taught universally in outpatient clinics in hospitals and things like that. It's a sort of way of measuring them. Not least of which is the last bit of his consultation was preparing yourself for the next consultation. So how you switch off the last one and move on to the next one, and not carrying the last consultation into the next one, which if you're seeing lots of patients in a clinic and if you've seen lots of patients in outpatients or regularly on a hospital ward, those clinicians will know you need to be very quick at just shelving that one and moving on to the next one, or that will affect what goes on for the rest of the day. So here is the sort of the simple structure. In fact, I've even called it a simple structure. There, see, go me. So, what we try and do at the start of any consultation, when you're sat down with a healthcare professional, is to do nothing. Our initial consultation usually starts off reflecting what was put on the triage note. So, I can see looks like you've come in to talk to me about, and then you can list off what the problems are. Or I can see you've come to talk to me about a lot of things. That's not a bad thing, that's just what it is. That's a fair reflection of it. And then we will say things like, and the word we tend to use, and the reason it's up there, is the story. Go on, tell me your story. And those who've seen me as a patient will know that that's a phrase I use repeatedly. At which point, the goal of the clinician is then to say nothing for as long as you possibly can. It's a tricky thing to do. And it takes a lot of training to get the registrars, the junior doctors, to shut up at that point. But the key thing is to let the patient talk to you. If you let the patient talk for long enough, they will almost certainly tell you what is wrong with them. They might not give you the diagnosis, they might not give you the exact solution to the problem, but they will tell you what it is they're worried about and what it is they need to do or to get fixed, or the problem that they need to have solved. And the key is to just sit there and encourage them to go through that until they have told you everything they wanted to tell you. So that's what I'm doing in the opening part of the consultation. So as far as your role in the consultation, it's to tell me everything that you think I might need to know. Because almost certainly I need to know all of it. There will be some more information I need later on in the consultation, but to start with, getting everything you think I need to know out there is absolutely vital, because that helps us work out where we go afterwards. It is not unusual, and I have the registrars on a stop clock, so the junior doctors, when I'm training them, I actually put them on a clock, and I will make them write down the time at which they say the first word after they go on and tell me your story. So I'll make them actually time themselves, right? So you might see, if you come and see the junior doctors, you might actually see them taking notes like that. That's keeping the notes, their trainer, their supervisor, me. The idea is that they go for at least a minute, that's the barest minimum, and my goal is to get them to say nothing for 3.5 minutes. Takes them a while to get there. Some non-verbal cues, some, carry on, thanks for saying that. So stuff that just encourages that isn't what I'm after, so that's fine. But so anything to encourage it, but about 3.5 minutes is what you shoot for. It's a 10-minute consultation, and I'm expecting the patient to do all of the work for the first 3.5 minutes. I'm a GP. I like hearing what people have to say. I will then follow that up with a series of focused questions. That's the bit where I tend to go into the yes-no questions, the closed questions, the questions about what it is I think are important. So you've said some things to me, and I will then pick those out. So I will usually say things like, I've heard you say, or it sounds, sometimes I'll use some slightly complex reflection, bring a whole bunch of pieces of things together and say, it sounds like you're talking about the following. Can I ask some other questions? And then there'll be some classic list of questions that we ask about, so the things you haven't told us and filling in the blanks. There will be some yes-no questions that have to be answered. Any woman of childbearing age that comes in with almost any problem will be asked if they're pregnant, because I can't prescribe or treat or do an awful lot with them unless I know the answer to that question. So there will be some questions about the pregnancy question. We wouldn't ask it of a lady who's a while beyond. Don't mention a young lady's age. We've already had this conversation. Thank you. But so yes, we will. But we will ask other closed questions. If there are red flag symptoms that we haven't picked up, have you been peeing blood? Have you been pooing blood? Have you had any chest pain? That you can see how exactly all of these go. These are clear questions that we might need to know the answer to, because they might radically change the course of where we're going with the consultation. So that's the point in those closed questions, is picking up the bits that you haven't said. Almost always the answer to all those questions is no. The reason you haven't said them is because they're not there. But I need to know that they are not there. So I'm digging for the negatives to make sure that we haven't just forgotten it. They've definitely not, we've confirmed that's not the case. We will then look to share a plan, and a good consultation at that point will then move on to shared decision making with the patient. It is often the case in a general practice consultation that there are choices for the patient to make as to what happens to them next. Sometimes I will have to make the choice for them, because there's a clear, you've got this history, this on the examination, we need to do this next. That's actually quite rare and unusual for there to be a clear pathway all the way along. Even if, for instance, we're talking about a possible cancer diagnosis, there is a shared decision to be made with patients here. Are we referring you to Oxford or Swindon? Because there's a choice here, and all the patients get a choice. They could actually be referred anywhere in England. I do get a small number who want to go to Reading, Gloucester, and even London, because that's where they work. So we need to, so even if the outcome is a clear clinical choice, in that it doesn't matter where you go, you're going to get the same thing happening to you, there may well be a choice about where these things happen. So what we will try to do is to share that decision making with the patient, to explain to them what the consequences of the different decisions that they could make are, and to ask them which one would be their preference. At which point they often say, "What would you do, Doc?" That, by the way, is the wrong question, because doctors are universally bad about taking care of their own health and universally bad about following their own health advice. Don't do what doctor would do. Nurses can be that bad. My mum was a nurse. It took her 48 hours of me whinging before she finally took me to hospital to get my green stick fracture of my arm diagnosed when I was 12.
Not that you hold a grudge.
No. That's fine. Actually, I needed their help at the moment because we've had it's not as serious, but there's a slightly tricky family problem going on at home at the moment. And I went to find out where my parents were, because they live only a mile out from my house, which is why I live here, because having children and grandparents living, well, that's dead handy, isn't it? To find out they'd gone to Dublin for St Patrick's Day. What's the point in moving a mile up the road from your parents so you can use them as emergency childcare when you need them? They're gone on holiday, having fun. But yes, shared plans in terms of tests, which tests patients want, what we can offer them, whether it's wise to offer those tests, what treatments are available, if there's more than one treatment, which one they want to do first. Perhaps they want to do two first, perhaps they want to try one and then the other. As long as these are all medically sensible and the risk is relatively low, and that is often the case with what we're doing, we can switch around the treatments as we need to, as the patients would like us to. Self-care is always on the list of choices. Any patient can choose to decline to accept medical advice. They frequently do. Everybody who comes into my clinic who smokes will be politely reminded that that's not healthy. They don't always go out and stop smoking. They can decline medical advice. It is entirely reasonable and not an unusual thing for patients to do. So self-care is always on the option, and we would always offer the patients the option of doing nothing. It might not be what I would like, frequently isn't what I would like, and it frequently isn't what I would suggest is the most healthy thing for patients. But patients do unhealthy things all the time. Otherwise, McDonald's wouldn't exist. Oh, did I say that on tape? Damn it, now I'm going to be sued. And then safety netting. The last part of the consultation, usually the last part of the consultation, is the safety net. If there is a risk of whatever is going on could become serious, what would that look like? When do you need to come back and ask for more help about this problem? Could it become serious, and do you need to go elsewhere? I mean, if there's a potential for this problem to become serious and you need to go to an emergency department, what does that look like, and where do you go? How do you arrange that? You know, when do you ring 999? The classic for that is sepsis in children. We have a sepsis advice leaflet in each of the rooms, and as a general rule, whenever kids come in with a fever, they are offered a sepsis advice form which says this is what sepsis, a treatable, life-threatening problem in children, looks like. It's only treatable if you get it quickly, so you need to get them into hospital. They don't need to wait 2 days for another appointment with Dr. Russ. They need to go to hospital to get sorted out. Now, about 1 in 1,000 children who come in here with a febrile illness will go on to develop sepsis in one form or another, but 1 in 1,000 is not actually that small a number when you realise how many febrile children we see in this building every week. That's going to happen. So that safety net enables the people to know, okay, so I've got 2 or 3 of these symptoms, I need to go to the emergency department, I don't need to ring my GP back, because it clearly says it. So it's about empowering the patient to make the right choices. And often people are scared of dialing 999 as a whole. There's a small number of people who dial it all the time. But as a general rule, the general public don't like it. It's quite frightening to pick up the phone and dial 999. If I've given them the leaflet that says if these happen, dial 999, people are way more likely to do it and not likely to hang on and wait. And so that's the other thing with the whole safety net process, is about giving people the authority to either call the GP surgery back, or to call 111, or to call 999, and to get those things moving. So that's the other part of the safety net system as well. Sometimes that's just a list of instructions, and sometimes it's actually a piece of paper. Depends on what it is. So that's the basic structure of a GP consultation, and actually any of our clinical consultations. And we aim to get that done in less than 15 minutes. That includes writing the notes up and requesting any tests and doing any referrals. So it's a bit tight on time, and that's back to that. So we're going to keep sort of revising the same sort of things: right patient, right clinician, right time. That ensures that we're getting the most, and that, because if you're in the wrong place for your 15-minute consultation, this is going to go wrong in a hurry, and it's very difficult to then get that back out in that consultation without having to use another consultation to resolve the challenge. So that's the main reason for triage, is to enable that to happen successfully. We've already discussed some of this, but things that help, so things the patients can bring with us to the consultation to help us. Symptoms, what symptoms you've been having and when, so the timeline of the symptoms, And the most important bit, the impact of the symptoms. The symptoms are the what. As a GP, the thing we are mostly interested in is the so what. So what impact are these symptoms having on you? Knee pain, swelling and stiffness in a teenager who spends his entire time sat at a desk playing computer games is going to be much less limiting than a teenager who is trying to play sports for a living or is doing an active job every day. It's the same problem, it's the same diagnosis, it's the same underlying physical issue with them, but the impact is going to be different and their needs will be different as a result of that. So we can't understand our needs and what we're trying to sort with the patient unless we can get the impact of it. The classic questions that we will ask when we're trying to elicit that from the question is, can you tell us what it is that you can't do that you need or want to be able to do because of this problem? So that's the sorts of phrases that we tend to use a lot, and it's one of the things that's asked on the digital triage questionnaire, and it's one of the things that the receptionists will ask as well when you speak to them. The impact is absolutely key. Relevant histories, your list of conditions, of course, that you have as patients will be on our system. So we're only interested in things we might not have the data on because it's come from somewhere else, weird and wonderful. Allergies, we don't have it's not always obvious. Drug allergies are fine, we'll have those recorded if you've ever told us about them, but we don't always pick up food allergies and other bits and pieces, and some of our drugs are based on foods. Peanut oil, for instance, does appear in a number of the medicines that we use, so that's not an unusual thing to come up with. So it is worth being aware of that sometimes the food allergies can overlap. And other medical allergies, so the hospital have said you've got a problem with a radio-opaque dye that they use in X-ray, for instance, which does again come up from time to time. They often don't bother to tell us, the GP, that because of course I don't do X-rays. So it's not actually that relevant to me, but it might be if I'm trying to order you a test in the hospital to get stuff sorted out. So those sorts of things. Family history, again, is tricky. Usually it's worth repeating that each time. We do try and write it into the care records, but the digital records that we've got and the way the data is maintained is not that robust about family history. That's because the whole data system needs a radical overhaul and update more than anything else, but it's outside of my control. It's a national system. So family history is also good. Trends, we're back to that whole stuff about home readings. Bring us the readings, not just a number. I'm less interested in the average than I am in the whole set of readings. And the other bit, this is the stuff that we've talked about again, your preferences, your goals. What do you want to happen about this? Many of you will have had the problem before that you're presenting to me with. If you've had the knee pain before and a treatment made it better, can you tell me please? Because I'm likely to arrange the treatment that fixed it last time to fix it again. But if you don't tell me that, I don't know that that's what's going on. So your preferences and goals are really important to us. We might find that we either can't do them or we don't agree that it is the least risky option in this situation. So we might have a discussion about it, but I can't even have that discussion if I don't know what is there. And again, that's why the online consultation system and the triage team will ask about that, because these are the things that really make a difference. So be prepared to tell us what your preference is and what you want to be able to get out of this appointment. That's absolutely fine. We need that information. As I said, we might not be on the same page, we might not necessarily agree about it, but at least I then know what I'm trying to resolve, and we can then come up with a shared plan that takes all of that into account. Can't do it if I don't know it. Does that all make some sense? Cool, lovely. Right, we talked about this several times already. Digital tools and online access. Right, okay, so we had to talk about digital at some point, didn't we? Because the government tells me I have to talk about digital in every tomorrow. Grr. Online services. So the NHS app exists. The NHS app is good when it works, it's crap when it doesn't work. We try our best to help our patients to fix it. Sarah set up the digital cafe. It's less of the we, more of the Sarah on that one. We do have some people here in the reception area who have some idea how to help people set it up. The NHS app is going to become more and more and more important because the government has insisted that all information and access to the NHS is eventually going to go to the app. So their 10-year plan is that everything will be arranged through the app. Your hospital appointments, your GP appointments, your access to GP surgery, your messages about health, your own health records, your hospital and our records, all of that will all be available through the NHS app. So like it or not, we're going down an NHS app pathway. Feel free to write to Wes Streeting if you don't like that. Not a lot more I can do about it other than say that's what we're going to do. We do have, there is a practice portal. It's slightly confusing here because the practice portal pretty much shows everything that's in the NHS app, but it's something called EMIS Access and was set up 10 years ago by EMIS before the NHS app came along, and it still continues this sort of legacy thing in the background. So there's actually two ways you can access your GP data. One is through the practice portal called EMIS Access, and one is through the NHS app. Pretty much they show the same information as each other. The only slight difference is that the EMIS Access, the practice portal, allows you to download the data as a PDF. So if you're digitally aware, you can actually download a copy of it. The NHS app doesn't allow you to download information out of the NHS app. So if you want to get a copy of your immunisations, for instance, that's pertain at the moment because everybody wants a copy of their meningitis immunisations at the moment. You can get it, you can download it out of the practice portal. You can't download it out of the NHS app.
What happens about old medical history? Because I've got very little on my NHS app.
Yeah,
I've
now.
been here 25 years, but it's not even all the stuff from here is on.
No, you are correct. The reason for that is all on your records. We've got it here. Up to the point where paper records switched to digital records. When the paper records switched to the digital records, which was a long time ago now, we're talking about 1980 something, because digital records have been in general practice since then. So we've got about 40 years worth of digital records here. The digital record system is, so prior to that there's a summary. So everything that came on the paper records when the digital was created, all the paper records were summarised, and that's there as a list of codes. After that, everything is there. The reason you can't see it is because the online access to GP medical records defined by the government in 2019, because it happened during the pandemic, because it was going to happen anyway and they didn't turn it off, it was October 2019 it was turned on. So what you can see is the data since October 2019. You can't see previous to that because they didn't set up the system so that you could see back in time. If you contact the practice and ask, we can set your system to enable you to access it. There's a code on the system to do it. What it needs is someone to, unfortunately, the legal issue here is that one of the clinicians has to review your data to make sure that revealing that data to you can't harm you or somebody else. Because I have a legal obligation to ensure that releasing the data to you can't harm you or somebody else. So someone's got to skim through that. That's the messy bit of that, and that's the reason why it wasn't done universally at that point. Because we went, well, that's a lot of work, guys, who's doing it? And they went, oops. So that's the reason for that cut-off date. But yes, we can, and we have a number of patients who do access it back from that. If you change a GP practice, it resets to the point of registration. So at the point where a patient registers with the Whitehorse Medical Practice, the online access starts from that point onwards. It doesn't go back to the previous practice.
But the new practice would still have all the information.
Yes, I've got all the information. It's all there. It's just you can't see it on the NHS app unless I release it. Yeah. Yeah. There's also a slight, now it wouldn't happen with a group like yourself because you guys are interested and you're here, so you're the wrong target population for the next statement by a long shot. But there are some people who misread what's written in the past. Some of your medical records will go back quite a long way because you've been alive for a few years now. Medical terminology has changed over the years. What you see a doctor writing from the 50s and 60s would not be acceptable to be read in the medical records now. But they are there and they are in your records. So part of the challenge is opening up access to things that would cause offence if you read them now, because a doctor who probably died 30 years ago wrote them about you 50 years ago. And they will be there. They will call patients an imbecile. They will say, this is a funny looking kid, but they look just like their dad. Those records are in the, those are there. Those are in our paper records downstairs in the building right now in multiple episodes. So all of these things, they will say, so all those sorts of phrases that would really, and then there are racial phrases in there which are unpleasant and unkind. and would not be the sort of thing you would expect to see in a modern medical record. But these aren't the modern medical record. They are a transcript of what was written at the time. As a consequence of this, it can be tricky to release all of these records to patients without giving them some sort of prep as to what it is they're going to see in them, because they don't always like what they read. And that it causes a lot of friction and time, and I don't have the time for a lot of that friction. So that's the other reason that the records are a little bit...
So, Rob, I'm a bit puzzled about results coming into the surgery and then getting into the NHS. If they can go straight into the app without the surgery signing.
Correct. Yes. Second is the case. The results coming from the hospital. So if I request a test result, the test goes to the hospital, and then the hospital sends the result back to me. It is immediately visible in the NHS app before I have seen it.
It is.
Yes.
Right.
Still takes a long time.
Yes. Some of them do take a long time to come back. Some tests do take a while to come through the system. But yes, they are immediately visible. They should be visible with a flag against them to say the GP hasn't seen them yet, but they are visible in the system. If the hospital requests the test themselves,
Yes.
so if a hospital consultant in a clinic requests the test, the results go back to them. They don't release them into the NHS app because the NHS app doesn't include the hospital system's notes yet. It will do, but it doesn't do that yet.
And if you send the blood, but not the patient, to Swindon, does that come in the NHS app?
Yeah, if I have requested a blood test to be performed in Swindon, which I can do because the Swindon man comes here and collects the blood and takes it to the Swindon labs and does the tests there, then it will come back through the app to me. If the patient was requested by a hospital consultant in rheumatology in Swindon, they will get it back. Now, one of the slightly confusing things is that sometimes we act as the phlebotomist for the hospitals. So patients may be given a blood card by a hospital specialist and told to get a blood test. They then realise when they go downstairs to the phlebotomy department of the Great Western Hospital, they'll have to sit there for 9 hours before they get their blood test done because they've got themselves in a bit of a mess. And instead they choose to book an appointment with us tomorrow. If they bring the card with them, we can do the blood sample and send it to the hospital. The test results don't come back to us because I'm not the doctor requesting it on the sticky label that goes in the blood test. The doctor's name on the sticky label as the requesting doctor is the one that gets the results back. So even if we've taken the blood, if it was a hospital request, the results go directly back to the hospital. I don't get to see them until the hospital consultant tells me about those results. If the hospital consultant tells me about the results. Sometimes I don't. Does that make some sense? There is a clear worry here. If I request a CT scan for a patient who I'm worried could have cancer, that CT scan is coming back into their records with the diagnosis on it. The patient may see it before I do.
But there is a flag on the NHS app
Yeah.
at the very beginning that says you may see things that no
Yeah.
one hasn't seen.
Yeah, absolutely. And that certainly is the case. Now, so often we warn patients that might happen before we do it. So certainly with something like that, where I think that that's what's going on or could be what's going on, I would normally tell the patient as part of that shared decision making, CT scan sounds great, we both agree to a CT scan, then I will say, you will be able to see this result immediately. If it comes back at 3 o'clock in the morning, and it may, because half of them are read in India, so they will come back at 3 o'clock in the morning, then you can look it up and see it. Knock yourself out. It's your notes, your results, but be prepared to read those and then have to wait 3 days for an appointment with me because I'm a bit busy and you're not going to get it in the meantime. If you want to do it the other way around, make the appointment, check whether we've got the results back in by ringing us up, and then make the appointment to come back and see me, and I'll tell you what it shows. It's up to the patients. I don't tell them what to do. I can just tell them what the choices are that they've got, and they can make their own choices. Different patients will react differently. Lots of people want to sit there and read their medical results at 3 o'clock in the morning. That works for you. Knock yourself out, dude. Whatever. It's not my choice thing to do, but I look at medical notes all day, so it ain't going to be my choice of thing to do, is it? Cool. Online consultation forms can be helpful for summaries. So often what we will do, if you put in an online consultation to us, so if you've put the online consultation in as a request for an appointment, we will often, after we've seen you, then be able to send a summary of what we've done with you back, because you put the initial request in, so we can send you the summary as a response to your online request after you've had the appointment with us. So one of the other reasons why online consultations can be really helpful is they open up a portal of communication with the patient that I can use to safely send information back to them, because that's the information you sent into me, and I've checked that that's you on the screen in my room, and then I've put a whole bunch of information about the consultation back through the system. So one of the other things now we can open up a new conversation, but only if you've got an email address already in the system. We'll come on to that one in a moment. So the other thing that we need to talk about, ambient voice and AI. So ambient voice technology has been around in general practice forever. I first started playing with this with Dr. Simon Cartwright, one of the former partners, senior partners here, about 10 years ago. It's a technology that listens to the conversation in the room and transcribes word for word what the doctor and the patient, and sometimes the patient's relatives, are saying, just as a list of who's who. And the cleverer it got, the better it was at picking out actually who said what. So identifying which one was doctor, which one was patient, which one was relative, and putting those next to it, almost like a script in the system. So we've been playing with those a lot for a long period of time. What has changed recently is that AI is caught up with that, and we can now take those scripts devoid of patients' names, so there's no details about who that individual is, and put it through an AI client, which is actually, we use here in this practice, an English AI client run by the same people who run our telephone systems. So it remains inside a secure server. So even though it's anonymized and doesn't have any patient information in it, also is run inside a secure server, so it can't get out. And that takes that script and turns it into a set of medical records. The advantage of that is it saves me having to use part of that 15-minute consultation to write the medical records, and also means if I'm rushed, I'm not writing rushed medical records. So they tend to be a better quality record, because the system is not worried about time, because it doesn't worry about it. None of the information is saved inside the AI system. Once it is generated, the output, the data is destroyed from within inside the system. So it's not keeping a backlog of all of these conversations. Actually, that's not entirely true. It keeps it into the end of the clinic. So if I'm here for a day, it keeps the information to the end of the day. So something comes up related to that later in the day, I can go back and fix it and alter it. Or, a patient rings up and says, I should have told you about this, but I forgot. That happens all the time. I can go back in and edit the system. But at the end of the day, the whole lot of the data is lost. So we are transcribing conversations and using them to draft the notes. They're also really helpful if, as a result of that consultation, I need to draft a referral to the hospital. Because writing good referrals takes time. There's a lot of information that I need to give to my colleagues in the hospitals as part of a good referral to enable them to do their job. And this system can take that and can compile that data into a good referral. And it is interesting that since we've started using that, we now get comments back from the consultants of, thank you for the detailed referral. Never used to get those before. I'm not actually sure they're any more detailed than they used to be, but I never used to get that before. But now you get that back again as part of it. Which is,
send 8-page screen dumps with every chest infection or snotty nose over 8 years.
Yep.
Not the problem.
No, indeed. Yeah, indeed. So, and this will combine that consultation into the. So one of the things you may hear us doing is talking to the computer in the conversation. So one of the things we will do is I will say, okay, so we need to make the referral. This is who we're referring to. We need to highlight this, and this, and we need them to think about this, and this. And the reason I'm saying that is both to inform the patient that that's what I'm doing, but I'm also talking to the computer. You'll hear me doing it if you come in to see us. You'll hear us doing it with the examinations now. So we will examine the patient's chest, and we will say, well, those lung fields are clear. And we will use phrases like the percussion note is resonant. That's a medical phrase, but I'll listen to the heart sounds, and I will call out to that, and I will say, okay, so your heart sounds are this heart valve is normal, that heart valve is normal. I'm not just telling you that I'm not finding anything on the exam. I'm telling the computer who's listening to us what to write in the medical records.
I was just thinking, consultants used to use dictaphones.
Yeah, absolutely. Yep, this is
dictaphone.
Yep, this is just the next phase. The dictaphones went to a secretary to be typed up. All we've done is cut the secretary out of the list here. Yep. No, not at all. The other thing it does do is it codes as well. So our system is almost there in that it picks up codes that are important to be in the medical record. So codes are structured coded data, which is a standard data set across NHS England. And as long as everybody's using the same data, they all line up. So things like blood pressure has a code, which means I can then chart blood pressures in the system. I can do maths from blood pressures if they're in as a numerical, structured, coded piece of data in the system. And what the AI systems are now doing is pulling that out and putting it in as codes, which is a much improvement on GPs who just couldn't be bloody asked.
15 minutes.
Yeah, sweet. We're almost at the end, actually. And I've talked about those privacy. Our system is set up to be entirely devoid of any patient information. So none of your patient-sensitive information is going into any AI system. And the AI systems we are using are entirely within an NHS portfolio, so it doesn't get out of that either. So for the moment, we've kept it there. We do not use AI in triage. And the reason why I do not use AI in triage is twofold. Firstly, we tried it, it was shit and didn't work. So we scrubbed it and didn't do that anymore because we couldn't get it to work. The best AI triage systems are 95% accurate. My GPs on triage are 99.9% accurate. They've got 4% to go before they're anywhere near where I am touching them, and they are a mile off of being in that space. So they're just not good enough, is the first reason. And the second one is the basic rule of AI is don't remove a human from the loop. Do not remove the human from the loop. Every part of an AI step needs a human to review what AI is doing to make sure it's not going off on one. Patients are increasingly using AI clients to contact the general practice. It's not actually a bad idea because AI clients know all of the things I've talked about today. So it tends to ask them the questions that they need to tell us and make sure that the information is coming through to us. I can see, usually, because we've got quite adept at it now, we can spot when a patient's using an AI client to write their online request for a GP appointment. The last thing I need is my AI client talking to the patient's AI client about sorting their appointment out without a human being in the loop. Because all of the AI research says that is very, very dangerous. So the other reason we don't do it is because I cannot safely screen out the patient's use of AI clients to contact the White Horse Medical Practice. And until we can resolve that, we will not be using it in triage. So triage doesn't use AI. A couple of quick myth-busting bits and pieces. Quick wins for patients. Here's some of the takeaways we're going to talk about. Write one or two biggest issues, biggest worries. If you can identify one or two big worries when you come to see us, we can resolve those worries. If we don't know what your worry is, we can't make you less worried about it. Blindingly obvious, really, but the number of times that doesn't happen is actually quite large. Bring your medication list if it's different to what we've got on our system. Arrive a bit early, that kind of makes sense, really, doesn't it? Please arrive on time. Yes, please remember your hearing aids and your glasses. If you can't hear me, we are going to struggle. I will want to show you things. If you wear glasses, if you wear reading glasses, bring your reading glasses with you. It sounds obvious, but the number of times that happens is really, that's why it's written up there, because it comes all the time. If you want to write something sensitive that you don't want to talk to the receptionist or anybody else about, if you want to keep it between you, me and the doctor on triage, you are welcome to do that. Write it down, put it on the form and send it in. And the more that can be disseminated to patients, the better. If you want to talk to me in secret, you can do so. I'm your doctor. That's fine. Please feel free to use the form and we can have a very clear, discreet conversation. The goal of the conversation at the end of the consultation is to agree a plan, and if there are red flags, warning signs for doing something in an emergency about it, to have those sorted. If you don't understand what the plan is, you need to tell us that you don't understand what the plan is. We will do our best to repeat the plan several times to make sure, have you got that? With some patients who don't get it very often, I might even ask them to repeat the plan back to me, but that still doesn't check they've understood it. It just checks that they've repeated the words back to me. So it really key, and the other key message to the patients is make sure you've understood what's gone on in the consultation. If you haven't, please tell us and we'll do something different. A couple of common myths that we just bring up, and we've covered these on various different times before. More tests does not equal better. That's you often get, my doctor was great, you ordered 27 blood tests. I've got a very different opinion of that doctor to you. That's not how it works. Testing is targeted. And the reason that testing is targeted is because testing has a false positive and a false negative rate. The chances of us actually picking up a truthful result on the test depends upon the chance of the patient having the illness you're testing for. So if the patient has a very low chance of having an illness, the tests have a greater chance of giving you a false result than a true result. And that makes things really complicated and can result in over-treatment or under-treatment as you're trying to work out where we're going. So tests need to be targeted, and they are based upon the risk of your patient having the illness you're testing for. You don't need a GP for everything. There's a multidisciplinary team that we have here. You may be directed to the multidisciplinary team because they are quicker, better, faster, and more appropriate than the GP. And no final diagnosis doesn't mean your GP's crap. No to final diagnosis means your GP can't work out what's wrong with you. It might take us a while to get there. Sometimes I don't do it all in 10 to 15 minutes. So the other method is feel free to admit with your GP that we haven't solved everything in one go. Work out what we're going to do next, and the plan will be how we move that forward to get towards a resolution. Some tests, a review, some time, more information from the patient. There's a whole variety of ways we can do that, but a GP consultant does not always result in a diagnosis, because sometimes I just don't know what's going on. Continuity is the other thing that's worth mentioning. We tried this really hard here. Feel free to reflect back to the practice if you think we're getting this wrong. Continuity matters because the clinician you're talking to has, over time, a better understanding of you, your history, and your problems, with good evidence that regular continuity with the same clinician for the same problem results in fewer tests, more accurate diagnosis, earlier treatment, and it is also important for long-term complications. So if you've got a long-term illness, it's important that you try and see the same clinician. For that reason, people managing long-term conditions with the nurses, we try and focus them back to the same nurse. If you're having a process with me to diagnose a complex problem, we try and bring you back to see the same clinician about it. We try very hard through our triage service to promote that continuity so the patients are getting the same appointments with the same people to resolve the same problems. If you feel that's not working, and if we get noise that's not working, let us know. We think from our data inside the practice that it is working because the data suggests that's happening the vast majority of the time. It's not always possible because sometimes doctors, get sick or get pregnant or their children get ill or, all of these things happen. So it doesn't work every time, but we do get very high levels of continuity and we work hard at that. Our triage system hopefully helps to promote it, but you can also help that. So can you book with the same clinician? Feel free to ask. If you're getting on with a clinician and you want to see the same one again, say that. If we don't know that, we don't know that. So feel free to ask. We expect patients to ask. And we even ask you in the Engage Consult system, who do you want to see? We're quite clear and transparent about that for that reason. Feel free to use online messages for clarifications. You get home and then you think, oh shit, I meant to ask about. Put a message back into the system and someone will try and get back to you with a quick answer to it. It might not, if there isn't a quick answer, because actually you thought there was one, then I think there isn't a quick answer to that problem. It might confuse things a little bit, but we'll sort out the answers to it. But if you need a quick clarification, feel free to ask. Online consultations are really good for that one. And please keep your contact details up to date. I need your mobile phone number and I need your email or I can't get hold of you. Cool. We can skip the next bit. The next bit's on GP contracts and how they work. We don't need those. That was the out-of-date bit, by the way. Cool. Excellent. So, key takeaways. Prepare, prioritise, and share what worries you. That hopefully I've showed that care navigation gets you to the right place at the right time. Use online access to review results, to track your own trends, and to ask if you don't understand what's going on with those. The tech support, so that's got to get garbled in there, hasn't it? That's me trying to update it, and the system has automatically auto-corrected me, hasn't it? Whilst you will see paramedics, nurses, physicians associates, physiotherapists, they are support, registrars, junior doctors. They are the supports that the clinician, the GPs, do remain in charge. If you think you need a GP to be in charge of what's going on, you need to say so. But if you don't say so, we can't do anything about that. Cool. That, I think, is my summary at the end of it. Anybody got any more questions?
I have.
Go for it.
You say that the care navigators
Mm-hmm.
will put you to the best clinician,
That's the goal, yes.
but are you specialising? Or,
So if we're talking about GPs,
just
Yep.
an interest
Yep.
or a specialist?
Yeah, so
Specialising.
We have no GPs here who are specialists. GPs who are specialists are a specific sub-branch of GPs. There is a specific set of words that they use in their title, and they have to have very specific postgraduate qualifications to do that.
The care navigator could put you to anybody.
Yes, well, any GP for any GP problem. Obviously, if you've got a musculoskeletal problem, it will be the physiotherapist. If you've got a nursing problem, like a wound dressing, it will be the nurse. So there are specialisations across the different types of clinicians that are here, but within the pool of GPs, or some of us have more interest than others in some illnesses. The goal of our interest is to keep up to date with the area of interest and to educate the other GPs to upskill them. It's not to be the GP that sees all of the problems like that.
GPs work in a hospital for at least one day a week.
Yeah, GPs don't anymore. No, most GPs don't actually go anywhere near hospitals. Hateful places, hospitals. Horrible, yeah, they did. Horrible buildings full of sick people. People get sick just because they are in the building. Why on earth would I want to go there? No, so none of our GPs work in hospitals.
Then they had a specialist plant.
Yep.
If they worked for it, went once a month to work with a dermatologist, or
Yep.
went once a month to work with a guy.
That's been withdrawn a number of years ago. Largely speaking, it didn't work. What it taught the GPs to do is to be overly safe, over-refer. Hospitals don't risk manage well. I am a risk manager, I'm a GP. They are not very good at it. Hospitals treat every patient that's in the hospital as if they are sick. That makes sense, really. If a patient is in a hospital bed, they should be sick. And if they're not sick, what the bleeding hell are they doing in a hospital bed? They need to get out because there's sick patients waiting in the corridor to go in the bed. So hospitals don't manage risk. They assume everybody is sick. GPs are risk managers who assume everybody is well until we prove they are sick. That philosophical difference is huge. And that's massively part of our training and the skill set that we work very hard to work towards is admitting someone to hospital is the last thing on our list of things to do, not the top of our list of things to do. Whereas hospital consultants want everybody in their hospital bed in the hospital to be treated. It's just a different way of thinking, and it's not wrong for them because they've got patients who are sick and need them in the hospital. So that's the difference. So no, none of us really go into hospitals anymore. The learning was not particularly transferable into general practice. And general practitioners are specialists in general practice. That is our point. We are specialist generalists. And working in a specific field breaches that generalisation, and in the long run it wasn't found to be particularly helpful.
Used to call it referral agents.
Yes, yeah. Gateway agents, referral agents, we're not those anymore. I can go through entire clinics without, it's not unusual for me to hit a week and only refer 1 or 2 patients. It's much lower down the list of things that we tend to do anymore. Yeah, cool. Yep.
I've got 2 or 3 niggles about things, none of which is hugely. Should I get a shopping list and
Yes.
go with them?
Yep, absolutely. Shopping lists are fine. We genuinely don't dislike shopping lists. Right. Often we find that shopping lists are not actually a long shopping list of 12 different things. Yeah. When we look at them, we often realise that actually it's 2 or 3 things with a whole group of different symptoms. So I can often tie things together. So that is really helpful, having the list of symptoms like that, because we don't often think they're as disparate as the patients do. So that can key us into where we need to go. If we are going to bring a list, please be able to highlight the 1 or 2 that are the most important, the ones that are having the most impact, the ones that are either the most worrying for you or the ones that are limiting you the most. Because I want to help you as much as I can in those 15 minutes. And if you've got the top 2, these are the top 2 things I actually need to get sorted now because they're going to cause me a problem with this or that. Those are the ones I want to start on, unless I see others on the list that are a priority that we need to do something about.
So how do I get through the first gateway when I ring up?
Oh, you just tell the team, I've got a list of, ring up and speak to the receptionist and say, I've got a bit of a list of things I want to talk about. Can you put these through to the triage people for me and get me an appointment? Feel free to use those words. And the ladies and gentlemen on the phone will write down what you've said and swing it through to the triage team, who will find you the right person to sort your list out. Or persons, if actually you need 2 or 3 different appointments to sort them out. Yeah, no, happy with that, not a problem at all. As I said, I prefer it that way because I prefer to know everything that's causing the trouble, because sometimes it's easier to get it all out of the way in one go, especially if it's all actually related. Yeah, no, absolutely. Yeah, they're absolutely fine. Yep, go for it. Give me a list.
If you see a GP and they say, we've got to send photos and some stuff off to a specialist team, I don't know whether it would be in-house or out.
Okay.
How long should one expect to wait?
Depends upon, firstly, they should tell you that when they're sending the photos off for a specialist review. There are two ways of doing it. There is a fast track, oh dear, we think this is serious, but we need to work out where to send the patient, in which case we should have an answer within 48 hours. And there is this one's more routine, and we're actually looking for them to guide treatment for the patient. So can you use these pictures to diagnose and treat the patients with me? They can take up to 6 weeks to get the answers back. So it depends a little bit upon where we're going with that. I mean, some of the pictures that we do send off are, oops, this really isn't very good. How do we, which clinic, when, how fast can we get this sorted out? Those questions are about pathways in the hospital. Hospital pathways are massively complicated these days, and sometimes we need to ask the pathway team in the hospital to tell us, well, where do you want this one? Because it's not always obvious which door you're going through into which clinic to get them sorted out. And again, right person, right clinician, right time for the right problem applies to the hospitals as well as us. So if we can get that bit moving with the photos, that can be what we're doing. Others are diagnostic help and support. They take a bit longer because the consultants have to get round to doing their photo clinics. Yay. Cool. Any more for any more? I think we've hit the 90-minute mark. Yeah, sweet, super duper.